merhabalar. Sabah serin, öğleden sonra sıcak İstanbul günü. İstanbul bir haftadır oldukça sıcak zaten. Oldukça hareketli bir toplumsal ortamdayız. O nedenle bir yandan işlerimizi, bir yandan öğrenme amaçlarımızı, bir yandan önceden verilmiş sözlerimizi sürdürürken ülkede de bir değişim, değişimde zorlanma dönemi olduğunu biliyoruz. Yani içimizde yaklaşımda fikirleri olan arkadaşlarımız da vardır ama zor bir zamanda da olduğumuz ortada. Ama buna rağmen hepimizi ortak birleştiren durumlardan birisi çocukların ihtiyaçları, çocukların gelişimsel ihtiyaçlarının karşılanması ve buna uygun yöntemlerin ülkemizde de evrensel standartlarda yerleştirilmesi ve yaygınlaşması. Çünkü iyi bir şey yerleşmeden yaygınlaşması da çok zor. Yaygınlaşmasını istiyoruz ama ana standartlarında iyi bir şekilde yerleşmesi temel amaçlarımızdan. O nedenle her alanda o işi iyi bilen insanlara ihtiyacımız var. Çok iyi bilen insanlara ihtiyacımız var. Çok iyi bilen insanların sayısı arttığı ölçüde onların da bilgiyi yayması artıyor. O nedenle bugünkü toplantı, Serap Hanım bana 4-5 ay önce, Serap Bostancı toplantıyı organize eden kuruluşun yöneticisi, Serap Bostancı Eren, bana bu konudan bahsettiğinde Profesör Rossetti'nin çalışmalarıyla aşinaydım. Daha ziyade dil terapisti arkadaşlarımızın aracılığıyla onlardan duyduğum hem ölçüm teknikleri açısından hem müdahale teknikleri açısından katkılarıyla bu vesileyle daha sonra da çalışmalarını gözden geçirme fırsatı da buldum. Erken çocukluk gelişimi ve özellikle dil iletişim becerilerinin gelişimini hem değerlendirme hem müdahale teknikleri konusunda dünya çapında bir uzmanla önümüzdeki saat 6'ya kadar olan zamanı beraber geçirmek şu andaki ortak amacımız, ortak hedefimiz. Ve bunun için bir aradayız. Hem aramızda değişik meslek gruplarından çocukların gelişimi ve ruh sağlığıyla ilgili çalışan arkadaşlarımız var. Hem çocuklarıyla ilgili gelişimsel sorunlar yaşamış ve bu konuda bir anlamda uzmanlaşmış aileler de aramızda bulunuyor. O nedenle hem gelecek olan sorular ve katkılar çok kıymetli olacak. Hem de duyulan öğrendiğimiz bilgileri biz de kendi pratiğimize yansıtma olanağı bulacağız. Profesör Rossetti, Wisconsin'deki Oshkosh Üniversitesi'nde aynı zamanda pozisyon olan bir öğretim üyesi. Ama temel olarak da özellikle bir pratisyen, bir klinisyen. Dolayısıyla sadece bir teorik bilginin ötesinde bize kendi uygulama alanında kazanmış olduğu şimdiye kadar biriktirdiklerini interaktif bir şekilde anlatacak. Sanırım toplantı sırasında kendisiyle bir konuşmada hani ihtiyacı olan vesaire çıkabilir. Çünkü ara vermemek gibi bir niyetimiz var ama tabii bir ayaklanma olursa verirse. Oradaki şeyde o nedenle tuvalet ve başka ihtiyaçlar sevgili arada çıkıp girmenin serbest olduğunu ben düşünüyorum. Yine anlaşılmayan bir nokta olduğunda o noktada durup sormak, tartışmayı ve soruları belki hani en sona bırakmak gibi bir şeyimiz yok. Son dakikaya kadar Profesör Rossetti'yi dinlemek ve arada tartışmayla zenginleştirmek niyetiyiz. Sözü daha fazla uzatmadan Profesör Rossetti, the floor is yours. Buyurun.
That is very kind of you. I appreciate that. I would tell you that I've been in your country less than one day, and I've already made many wonderful friends, and I've really enjoyed the food. That's a good thing. I bring you greetings from the United States, and I spent some time before I came trying to understand your system of education, and trying to understand your medical system, and the way in which you go about providing services for children with special needs. I've mentioned to several individuals already that this country, Turkey, has made more progress, at least in terms of your legislation. You've made more progress in 15 years we did in the States in 30 years. You've done very, very well legislatively. Now, I know that some of you feel that the actual delivery of services hasn't caught up with the legislation. It'll always be that way. It'll always be that way. You'll never feel that you caught up. I've had several of you ask me about my family. I will tell you right up front, I have 4 daughters and 4 granddaughters. So being in a room mostly of women is nothing new to me. The advantage is that I don't have to wait in line to use the laboratory because there's not a lot of men here today, and that's a good thing. We have only 3 hours together. It will go very, very quickly. I want you to feel free to raise your hands if you have questions at any time. And you have perhaps certain goals that you set for this time together, only 3 hours. What we will do this afternoon is 3 hours from about 30 to 35 hours worth of lecture material. So I desperately don't want to frustrate you by trying to cover too much. I would rather do a few things well than cover too much ground. But perhaps you have certain goals that you have, something you'd like to take away from our time together. And just as you have goals, I have a goal. And my primary goal, even in the context of a brief afternoon together, is to serve as much as I can as a resource person for you. And in the context of serving as a resource person for you, there are 3 things I can bring to you. And I want you to feel free in taking advantage of those 3 things. Let me explain. One of the things I can bring to you is a familiarity with the world's literature on children with special needs. It doesn't matter to me what your primary academic discipline is, whether you're from the medical community, psychology, whatever disciplines are here. I know your literature. And when you ask me a question, I will do my best to give you a data-based, literature-based answer. There will be some instances in which my opinion differs from perhaps what you read last week or last year. I will always point that out to you. I'll always let you know when I see things a little bit differently, I'll explain why. So one thing I can bring to you is the world's literature. The second thing I can bring to you is what I refer to as best practice. And by that I mean I've had opportunity over the years to visit clinics and centers and schools all over the world, some of them multiple times. And I would tell you I've seen what works and I've seen what doesn't work. I've seen what programs have had good impact and what programs reflect perhaps wasted time and wasted effort. I will bring you, in the context of what we will talk about today, examples of best practice, places I've been where they're doing things well. That's the second thing I can bring to you. The third thing I can bring to you is by way of what it is I have done primarily for the past 40 years. I'm asked repeatedly, how do you spend your time? Do you sit at a computer doing this all day, writing or researching? And I would tell you no. I have spent the bulk of that 40 years doing exactly what you do. I use the term clinician in a general sense. If you have anything to do with families and children with special needs, you're a clinician. I'm a clinician. And everything I've written and everything I speak flows from 40 years of intense interaction with families, with children, with parents, and with you. I will bring to you this afternoon a never-ending stream of experiences I've had with families and children. My contention is that if we ever stop learning from the families that we work with, we should go find something else to do. I have kept for 37 years a parent journal. Every time a mother and or a father says something to me, and I step away from that thinking, that was very insightful, or that really grabbed my heart, or that was very powerful. I've written those things down for 37 years. I will bring you never-ending stories of those experiences. I will tell you about those times when I've done well, and I'm no different than you, those times when I've literally stuck my foot in my mouth. And I make the same mistakes you do. And we never stop learning from families. Now, I want to begin this afternoon by asking you a question. This is the most frequently asked question I receive anywhere in the world. It doesn't matter who the audience is. About a third of my audiences to a half are physicians representing different disciplines around the world. It doesn't matter if I meet with administrators, I meet with governmental officials, it does not matter. This is the most frequently asked question. Are you ready? And I want you to make eye contact because I know when you're going to look away. Okay, here's the question. Does what we do with children make a difference? In other words, are the services that we provide to children and their families, and let's limit it birth through 5. I can make a case, I'll make a case for older than that, but just for this part of the discussion. Do the services that we provide for children birth through 5 work? Does it make a difference? Is there efficacy, effectiveness to the services that we provide for children birth through 5? Now, when I ask you that question, what's your answer? You have to vote here now. You can't withdraw. What is your answer? Yes. When I'm asked that question, I answer as quickly as you do. Yes, it works. Yet having said that, I get put in the position, and perhaps you do as well, of having to answer the very difficult follow-up question. What's the follow-up question? Prove it. You see where that comes from? Does early intervention work, the services we provide? Yes, the world's literature overwhelmingly supports it. From the pediatrics literature to the psychology literature, it doesn't matter where you go. The efficacy, the effectiveness of intervention is well established. But then the question becomes, prove it. Can you do that? Can you prove the effectiveness of the services that you provide? See, now's when you break eye contact. And when we talk about the effectiveness of the services that we provide, we cannot afford to limit that definition on the basis of how much the child changes over time. You know what I mean. Let's say you assess a child in September, and then over a number of months you provide your intervention, whatever that looks like. And then you assess that child again in May. And we assume that the difference between September and May is a measure of how effective you were as a clinician. See? We would call that child change as a measure of effectiveness. Now, do you know what my response to that is? Thank goodness for maturation. It's a very, very good thing that children change even in spite of us. All children change. And so child change may not be the best measure of our effectiveness, and yet that's what everybody looks for. Parents want their child to change. School administrators and those perhaps who are paying for services, they want us to be able to demonstrate that it's because of what we did that this child changed over time. And one of the things I would strongly encourage you to begin to think through is for many of the children you will see, listen to how I word this now, no matter how effective you are as a clinician, no matter how good your school is, no matter how many therapists, teachers, educators work with that child, you will have children over the course of your professional career who will make little, if any, measurable or significant child change. Is that right? If you do it long enough, you will have children that will not make demonstrable, large child change. Does that mean you weren't effective as a clinician? clinician? I don't think so. I don't think so. See, perhaps we should talk about cost efficacy. In other words, would it save the Turkish government long-term money to provide services for children at earlier ages? You understand that question? Let me give you the most current numbers that we have in the States. We have very aggressive legislation in the States that mandate services for children at birth. I'll give you the US dollars. For every dollar we spend on a child under the age of 3, it saves the local school district $6 later on. So it's $1 now or $6 later. So maybe we should talk about cost efficacy. Will it have an impact on reducing the costs to an educational system if we see children earlier? Yes, the answer to that is overwhelmingly yes. So, child change, and that may not apply to every child. Cost efficacy, okay? Maybe we should talk about program efficacy. In other words, what should an effective program of special education look like? Should it take place in the home? Should it take place in a center? Should it take place in school? The literature is very, very clear on that. Okay? The most effective models for treatment suggest that treatment provided in the home for the first year provides for the best long-term efficacy. The literature does not support a center-based program for the first year. After the first year, center-school combination affords for the best outcome. Okay, so we can talk about program efficacy. What does that look like? Perhaps we could talk about curricular efficacy. And by that I mean, what should we build into a program of education that affords for the best outcome for the child? What developmental domains should we focus on early? And again, the literature, the pediatrics literature in particular, is very, very clear on this. The single developmental domain that is most highly correlated with later school success is communication skills. Let me say that again now. The single developmental domain that is most highly correlated with later educational success is communication skills. And frankly, you don't have to be. Sometimes it gets in the way. You don't have to be a speech and language person to make that happen. Sometimes that gets in the way. Okay? Let me share with you the most current psychological research, the human development research that I know of. It will tell us this. Those children that enter the elementary grades, and we're talking 5 now, at 5 years of age, those children that enter the elementary grades possessing an age-appropriate system of communication generally do well in schools. Those children that enter the elementary grades that do not possess an age-appropriate system of communication generally struggle early in elementary school. Listen to the second part. They struggle early in elementary school and it doesn't go away. And so one of our goals as educators, particularly if we're treating children under the age of 5, is to ensure that we do everything we can to promote their communication skills from the very earliest points in time. Now, I don't mean to ignore the need for physical therapy or occupational therapy or any of the other treatments that you provide. But if you have to choose one domain to stress, it must be communication skills. So we can talk about cost efficacy, we can talk about child change, we can talk about programs, we can talk about curricular, but the most current area in the world's literature is this. And frankly, this is where I've devoted the majority of my time the past 7 years or so, is we can talk about family efficacy. Do we make a difference for the families of children with special needs? Now, when we talk about family efficacy, that is a wide area. It's a big topic. In some parts of the world, we can't even define a family. If there's one thing I've sensed here in Turkey within 24 hours is how highly your culture values the family unit. It's substantially elevated in Turkey. It is not that way in other parts of the world. I wish I could tell you it was that way in the States. We can't even define a family anymore in the States. That's not a problem for you in Turkey. So when you're thinking, does what I do make a difference? Is it efficacious? Is it effective? I would strongly encourage you to think broader than did this child change from point A to point B. Because if that is your only focus for effectiveness, there will be children in your caseloads who will make minimal developmental change simply because their disability, if that's the right word, their educational needs are so profound. Now, I get asked repeatedly, does it work? And I've just said to you, yes. And I've tried to expand the definition of efficacy. But I want to take you right to the world's literature on human development. Because people then ask, okay, if it works, if it's effective, what factors contribute to that? What are the things that make what we do work? Now, to the best of my ability to review the world's literature, and just trust me, I'm good at it. To the best of my ability to do that, I note there to be only two things that contribute to the effectiveness of the services that we provide. And depends on who you read in the pediatrics and human development literature, but you will see some cite this number. 85% of our effectiveness is due to these two things. 85% of our efficacy is due to these two things. Anyone want to suggest what they are? Anyone? I've already given you some clues. Okay, let me give them to you for time's sake. One of the things that contributes to the effectiveness of our services clearly across the globe is age of identification. I can summarize all of the world's literature for you in this way. Those children we find early do better than those children we find later. Now, trust me, this is a huge topic. We could literally spend 6 hours, that's how much material I have, in discussing lowering age of identification. Okay? I'm going to give you just a little bit of that. I take a bit of a non-traditional approach as it relates to lowering age of identification. Okay, from my perspective, the best way to lower age of identification is for you in your local community to become intimately familiar with your local infant mortality statistics. Okay, now I see the looks on some of your faces. Why do I need to find out which babies are dying? They either don't leave the hospital or they don't survive long enough to be identified. Well, if you think about it, because of enormous advances in pediatrics and neonatal medicine, enormous advances, the same factors that contribute to infant mortality are the identical risk factors for surviving babies that contribute to later patterns of developmental delay. So I did some research on your infant mortality statistics. I think you rank 19th in the world. That's pretty good. Turkey ranks 19th. That's last year's numbers. That's pretty good. Okay, you rank very well. Okay, and your infant mortality statistics, if you measure the percentages, I've looked at them over the past 10 years, have dropped almost as fast as any place in the world. So you've done well as it relates to prenatal care, obstetrics, gynecological care. Turkey has done well, but you still rank 19th. So who's dying in Istanbul? What babies are you losing and why? You see, if you know who they are, and you know the factors that contribute to infant mortality, you can then put in place a more effective system of child find. In other words, you can educate your community as it relates to those factors and how they contribute to the potential for later patterns of delay. And I wish I had 2 hours to develop that. I would show you infant mortality statistics for Turkey and for around the world. Find out who's dying. Okay, that's one way to lower age of identification. There's more. So, 2 things now. 85% of our effectiveness is due to these 2 things. One of them is age of identification. Those children that we find early do better than those children we find later. What's the second thing? This is the most current, hottest topic, I guess is a way to say it, in special education, particularly early identification, is caregiver involvement, parental involvement. Okay? Well established. Let me summarize it. Those children whose caregivers are involved in the process very early do better long term than those children whose caregivers are not involved in the process. So, if you want to establish in this country an effective program of education, find them early and do everything you can to engage the caregivers from the very earliest points in time. Now, I'm going to take you someplace right now that you probably haven't thought about, but that's okay. One of the advantages of being with you here is that I can say anything I want, because I don't work with any of you. And I'm going home. And so I want to shake up your thinking a little bit. Okay? I have been watching you for 30 years. I'm one of you now, but I'm also an observer of us. I am strongly of the contention, I am overwhelmingly of the contention, that the bulk of responsibility for losing caregivers to the process, are you with me? The bulk of responsibility for losing caregivers to the process is your fault. I've got 3 fingers pointing back at me. We are the reason why caregivers are lost to the process. Now, I see the looks on some of your faces. Okay? Let me encourage you to ask parents when their child comes into your caseload. Ask them this question and write down their answer. And word it just like this. Ask them this question. Mother and or father, what are your strongest, earliest recollections surrounding the set of circumstances when you first became concerned about your child's development? What do you remember earliest and strongest? Ask them that question. Frankly, they're dying to tell you. No one ever asks them. And I would tell you, after you ask them that question, do not be shocked at all by the answer. This is one of the things I tell my medical colleagues to ask the first time they visit. What are your earliest, strongest recollections? Let me give you some examples. I had a father tell me one time, a younger father, I asked him that question. This is a quote from this young dad. He said, do you know what I remember, Dr. Rossetti, earliest? I remember in the delivery room when my son was born, when instantly nobody would look me in the eye. That's a particularly strong statement, is it not? You see, that young father perceived a sudden change in the atmosphere and the communication that was taking place in that delivery suite where his son was born. Now, that young dad was 26 years of age when he answered that question. If he lived another 80 years, he would never forget that early experience. Ever forget that early experience. After you ask them that question, then ask them this question. These are questions I have learned to ask parents over the years. And you word it however best fits the family that you're working with. Ask them this question. What is the most insensitive thing anybody has ever said to you about your son or your daughter? What's the most insensitive thing Anybody's ever said to you about your daughter? Write their answer down. Okay. But here's my observation. You won't even have that question out of your mouth, and they will have an answer. And 9 times out of 10, guess who said it? Guess who said it? You did. Or I did. See, every time we have those early exchanges with family members, mother and or father and or extended family, what we say has an enormous potential for either engaging them in the process, which is half of my effectiveness, or putting up a barrier. This is what I tell my students. This is what I tell the medical community a lot as well. Listen to how I word this now. Don't wonder if. Just assume that by the time you meet that family for the very first time, that mother and father have already been, forgive my language, beat up, bruised, and battered by the system. Don't wonder if, just assume it to be the case. You see, that's why when you want them to be fully involved in the process, and they put walls up, in large measures because they've learned not to trust us, because we've said some insensitive things, or we've not made them feel like they are an important part of the process. Let me share with you along those lines a research article that I published a number of years ago. I work extensively in neonatal intensive care nurseries, and at this particular hospital I did this research. We interviewed 60 mothers on the day that they were taking their baby home from the hospital. Now, these babies had been in the hospital for varying amounts of time. Not all of them were premature and low birth weight. Some were born with various medical, genetic, metabolic, chromosomal complications. But on the day they were walking out the door, I interviewed 60 mothers. And we asked them a wide variety of questions. But one of the questions we asked them was this: as you go home today, what is your strongest feeling? What's your strongest emotion today as you're walking out the door with your son and with your daughter? What do you think they answered? Number one, far above everything else, it wasn't fear, it wasn't joy, it wasn't relief, it wasn't any of those. It wasn't anxiety. The number one emotion, far and away number one, and this caught me by surprise, was anger. It was anger. Now, I went back and interviewed those mothers, and I asked them, tell me about that. What is it that made you angry? What is it about that experience that made you angry? And they're very honest. They will tell you. They will say, I was angry at the doctors and the nurses. They did not treat me with respect. They didn't give me any time. They were always in a hurry. I was angry at the hospital. They only let me spend 10 minutes an hour with my son or with my daughter. Okay. I'm angry at my employer. I spent so much time here at the hospital with my child that I lost my job. I'm angry at my mother-in-law or my father-in-law. We have 4 other children at home, and they would not come and watch our other 4 while we were spending so much time here. Okay. Mothers will say to me repeatedly, I'm angry at my husband. He just doesn't get it. Okay. And I would tell you, men are in again in the professional literature. For about 15 years, as it relates to early childhood and special education, you didn't see anything regarding fathers. Men are in again. And I can summarize that literature as it relates to what it says about men in this way. We don't get it. The word I like to use is, may fit for you in this country, men are dense. We have thick skulls. We don't get it. You're supposed to clap at that now. We don't get it. See, that has direct, clinical implications for you and I. That's direct clinical implications. What that says is, if I'm in an examination room with a 2-year-old or a 2-day-old, it doesn't matter, and there's mother and there's father, and I'm in there with this baby, how many babies are in the room? 3 babies. She has her baby, he has his baby, I have my baby, but as the professional, it's my job to help us all understand the same baby. There was an article published in the Journal of Pediatrics 2 years ago that listed 47 different possible occurrences in the life of a child with special needs. And it asked the mother to rate them and the father to rate them. In every single one of those 47 events, there was a statistically significant difference between the way in which the mother perceived it and the way in which the father perceived it. Huge. That's huge. And one of the best gifts as a professional, no matter what hat you wear, one of the best gifts as a professional that you can give to your families is to help everybody see the same baby. Okay, I'll share with you one more story, just to reinforce that much of the reason why our families are lost to the process is our fault. Okay, I interviewed a mother in the States a number of years ago. She had been delivered very difficult information from a geneticist. This is one of the more prestigious hospitals in the country, and I had lectured there. And she had been given very difficult information, lifelong educational and medical complications for this baby, relatively rare genetic syndrome. And I always ask mothers this question: tell me about your communication with your doctor. Tell me how he or she did in sharing difficult information. And we have choices. If a mother tells me more than once that her doctor, he or she, was insensitive to her, then I usually call that doctor. And they will take my calls. And I'll say, you're losing these guys. You're going to lose these guys. You need to alter the way in which you're communicating with them. So when I asked that mother about her communication with her doctor, she said, the doctor was wonderful. Compassionate, gentle, took time with me. This is a geneticist now. But then I asked her this follow-up question: how did receiving that difficult information make you feel? Now here is a word picture I would like you to keep in your minds, because this applies to every family you ever interact with. That mother said this. Remember now, the doctor was compassionate, took time, was gentle, answered her questions, but she said this, and this has stuck with me now for many years. She said, I felt like that doctor had just shot me in the heart. That's an incredibly powerful statement, is it not? Isn't that powerful? See, who's going to talk with parents within the next week? Let me see your hands. Who? Yeah. Who has the gun? Yes. Yes. Who else is going to talk with parents? You have a gun. Every time we interact with caregivers, it's a very delicate exchange. Now, are there times professionally when we have to pull the trigger? Of course there are. That's not the point. Where it's ethically, professionally necessary for us to pull the trigger. But I would tell you, if that ever gets easy for you, the delivering of difficult information, we don't need you in special education. Certainly we don't need you in medicine. If it ever gets difficult, easy for you, that should never be easy for you. And I always keep that word picture in mind. I tell my students, when you talk to family members, you've got a gun in your hand. And if you need help in learning how to communicate difficult information, I can help you with that. Okay, I've been doing it for 40 years, and I have made as many mistakes as anybody out there. Okay, so what contributes to your effectiveness? 85% of it is due to what? Age of identification. How can we lower it? Find out who's dying. And the other part of that is the degree to which the caregivers are lost. My experience has consistently been this. When caregivers are lost to the process, they're not lost later. They're lost from the very earliest exchanges. They're not lost at 5. They might be lost at 5 months. And once a caregiver is lost to the process, it can be very, very difficult engaging them again. It can be very, very difficult to do that. So when you're asked what contributes to the effectiveness of what we do, it's not necessarily the kind of program you're in. I know it's not the degree you have. I know that's not the case. It's not the curriculum that you build in. It's simply the age at which you identify the child and the degree to which the caregivers are involved. Okay? Now, sooner or later, someone is going to sit down and assess a child. Many of you, that's the hat you wear. You, in concert, in combination with the medical community in this country, will have to assess a child and determine whether that child, for us it would be whether that child qualifies for services. Now let's talk a little bit about assessment. Okay? And this has been a particular interest of mine over the years. For many of you, perhaps, you have adopted the mindset that assessment means giving a test. All right? And there's no shortage of tests out there. There are multiple assessment instruments out there. The whole idea of giving a test, let me give you some background as to where that comes from. That is very much giving a test, coming up with a diagnosis. You will not hear me use the word diagnosis much. I'll explain why. But giving a test and coming up with a diagnosis, it is entirely appropriate. It fits in a medical model of disability. Okay. From the medical perspective, let me give you the medical perspective on disability. Let me give you a little phrase that I think will help us understand. This is helpful. Okay. From the medical perspective, here's how the medical community would think. Diagnosis dictates treatment, which indicates outcome. That is entirely appropriate medically. The medical community is diagnostically driven, and it works. If you go to a physician and you have a number of medical tests, that physician will likely not prescribe treatment for you. Medication, surgery, therapy, they won't prescribe anything for you until they know what? What's wrong? It fits in medicine. It is entirely appropriate in medicine. It does not fit in education. And I truly hope you hear that in the way in which I say it. I'm going to expand upon it. A diagnostic model does not fit in education.